Hey everyone, welcome back to the channel. So today in this video we'll try to cover most important rheumatological topics for AMC part 1 and I've tried to include the topics like osteoarthritis versus rheumatoid arthritis, then Sjogren Syndrome and Polymyalgia Rheumatica and many more topics. So let's get started with osteoarthritis versus rheumatoid arthritis. So we are starting off with osteoarthritis. So now there are few key details that you have to remember about osteoarthritis and rheumatoid arthritis. So in osteoarthritis, as it is a degenerative joint disorder, so it occurs mostly in the fourth or fifth decade of life. So mostly you have to look at the age of the person in the question stem, and it will kind of give you an idea in which direction you have to go. So more than 50, more than 60 is the age that we are looking for, and then also important that after the use of that particular joint the pain will increase because it is a degenerative disorder and there is wear and tear of the particular cartilage, so the pain will increase. Next is the joint involvement. So there would be a asymmetrical joint involvement, and the person, because of the cartilage knee disruption, and it will start medially, so that's what can cause bow leg to the patient. And there are no systemic symptoms involved in osteoarthritis. It is basically a wear and tear, normal physiological process. So don't dwell up more into this topic. Now the important thing is X-ray finding, because maybe in the questions time you'll get a X-ray of it, and then you'll have to decide how would you diagnose it or what is the treatment that is being given according to Australian guidelines. So I'm going to focus on the X-ray findings now. So all the findings that we are seeing in X-ray are because of the wear and tear. So there would be osteophytes, loose bodies would be there, subchondral sclerosis, or bone cyst would be there, subchondral bone cyst would be there. Other than that, the thickened capsule would be there, and two of the most important findings are Bouchard's nodes and Aberdeen nodes. You have to remember this. Just look at the photo. These are the nodes. Just please remember this. Now for the management, we are starting off with non-pharmacological measures. Like we'll ask the patient to do strengthening exercises because it is as it is age related. So mostly the first answer that we have to mark is do strengthening exercises, conservative treatments. Then only after that we are moving to the pharmacological therapies. So pharmacological therapies would be primary is topical NSH, or then after that oral NSH maybe we can start. And for the flare-ups we have to give simple paracetamol. Now for moderate to severe pain, we'll give intra-articular corticosteroid injections, and there is a specific drug that is duloxetine. We are giving it in chronic osteoarthritis with depression. So this is like the pharmacological therapy, and the definitive treatment would be we have to replace the whole joint only. So the next one is rheumatoid arthritis. It is contrary to osteoarthritis. It is an autoimmune inflammatory process is going on, and there would be formation of the pannus. These are basically proliferative granulation tissues, and because it is occurring because of an autoimmune condition and inflammation is there, and it can erode the articular cartilage and bone. Important thing, it is associated with three things. One is HLA-DR4, the second one is rheumatoid factor positive, and the third one is anti-CCP. Anti-CCP is anti-cyclic cetylunated peptide. So these are the antibodies, and it is specific to rheumatoid arthritis. Then another important thing that it improves with use, and there would be systemic signs along with the bone pain, swelling, or morning stiffness, and usually the morning stiffness lasts for more than 1 hour. Now the systemic signs were fever, fatigue, and weight loss. Now there are two important syndromes that are associated with rheumatoid arthritis. So first is Felty syndrome. So Felty syndrome is rheumatoid arthritis with this mnemonic SANTA. I took this mnemonic from first aid. So this is what SANTA stands for. And then the other syndrome that we have to remember is Kaplan syndrome. Yeah, so Kaplan is rheumatoid arthritis with pneumoconiosis. So these two syndromes, just keep in mind, they can ask this because Felty syndrome they have asked in recent recalls also. So just remember these two. Now the X-ray findings. So there would be pannus, there would be synovial proliferation, hypervascularity because of the inflammatory process. The synovial fluid will increase, and it will have the inflammatory markers also, and then bony erosion can occur. Now these two important things are there. One is swan neck deformity and the other one is Botnier's deformity. You have to make sure that you remember that these are associated with rheumatoid arthritis. Now the treatment. If it is an acute scenario, less than 3 months, then we'll have to give simple NSAIDs or even glucocorticosteroids we can give. But if the disease is not resolving, the symptoms are not resolving, then we'll have to shift to conventional oral DMARDs. So if the patient is having low severity, then hydroxychloroquine or sulfasalazine we can give. Or if the patient is having moderate symptoms, then methotrexate we'll have to give. One thing, you have to avoid giving methotrexate in pregnant women. And then still, if the disease persists, then we'll have to switch to biological DMARDs that are TNF-alpha inhibitors. That could be infliximab, etanercept, and that's it for both of them. Another important thing is you have to avoid methotrexate in patients with chronic liver disease or with significant pulmonary disease. This is a fact that I got from eMedici, so just follow through it. So the next one is Sjogren Syndrome. Basically, two things you have to remember. It is the destruction of exocrine glands. One is lacrimal, the other one is salivary gland. And the symptoms would be because of the dysfunction of these two glands only. So first symptom is keratoconjunctivitis sicca. It is basically decreased tear production and there would be corneal damage. And the patient can describe this feeling as gritty or sandy feeling in the eye. Then next one is xerostomia. So basically decreased salivary production, and then it can cause mucosal atrophy or fissuring of the tongue. This is the photo that I have attached. Next is, there are important antibodies that are associated with Sjogren syndrome. So rheumatoid factor could be positive, but that is sensitive. The specific antibodies that are associated with Sjogren syndrome are antibody SSA or antibody SSB, also known as anti-Rho or anti-La. So this is important. They can mention these antibodies in the question stem and you'll get to know that we are thinking about Sjogren syndrome here. The complications that are associated with Sjogren syndrome could be dental caries, or it could be maltoma, parotid enlargement. Now for the diagnosis, this is important. We'll have to do salivary gland biopsy, and in that we'll find focal lymphocytic features. Now speaking of the treatment, if the disease is mild or moderate, we are dividing treatment on the basis of eye or salivary gland. So for the eye, if the disease is mild to moderate, we are using artificial teardrops, and if the disease is severe, then cyclosporins we are using, or we can refer the patient to an ophthalmologist. Now for the dry mouth, we are advising the patient to increase their water intake, to have a regular dental reviews, or they can use pilocarpine 5 mg oral. This drug is mentioned on RACGP guidelines, so I have taken this directly from there. And if the patient is having extraglandular symptoms, for that we can use hydroxychloroquine, methotrexate or rituximab. That's it for the treatment of Sjogren syndrome. Next topic is seronegative spondyloarthritis. So basically it is arthritis without the rheumatoid factor. There would be no anti-IgG antibodies present here. It has the strongest association with HLA-B27. You have to make sure that you remember this. Now there is a mnemonic that is PAIR. I took it from first aid. So PAIR stands for psoriatic arthritis. A is ankylosing spondylitis. I is inflammatory bowel diseases. And the last one is R, that is reactive arthritis or Ritter syndrome we can say. So psoriatic arthritis, as the name suggests, there would be psoriasis, skin finding, and there would be arthritis. So pain would be there and different body parts would be involved, but then there is a specific X-ray finding that is associated with psoriatic arthritis, that is penicillin cup deformity. It is very much clearly visible on X-ray. You can look through it on Google. And then the next one is ankylosing spondylitis. I have discussed this topic in my previous video, just go through that. The only thing you have to remember here is bamboo spine would be seen in the X-ray when we are doing this. And then we have inflammatory bowel disease. I'll discuss the topic in GI section. Anyways, you'll have to remember this Crohn's disease and ulcerative colitis are involved in inflammatory bowel disease. The last one is reactive arthritis. So there is a triad, that is conjunctivitis, urethritis or arthritis. So there is a mnemonic also, I took it from first aid. It is can't see, can't pee and can't bend my knee. So this is the mnemonic for it, and then it is associated with, so there is an infectious disease association here, as this reactive arthritis is also seen as a feature of Shigella. It is also seen with Campylobacter jejuni or E. coli, Salmonella, Chlamydia or Yersinia. So you have to remember this. We can make this integrated review of this topic in micro also, and then we have discussed the symptoms that are seen in reactive arthritis here only. That's it for this topic. So next one is systemic lupus erythematosus. It is a huge topic. The only thing that you have to remember is that it is a type 3 hypersensitivity reaction. There would be decrease in early complement proteins that are C1q, C4 or C2. So this would be pretty much visible in the question stem, and then classic presentation is like a facial rash would be there, and it usually spares the nasolabial fold. This is important because there is another condition, that is melasma, that does not spares the nasolabial fold. And joint pain would be a specific feature, and then it is more common in females of the reproductive age. So this thing also you have to make sure that you remember. So there is a mnemonic, that is rash or pain. This includes all the features that are associated with SLE. So it starts with a rash. It could be malar or it could be discoid rash. So this picture that I have included here. So first one is malar rash and the second one is discoid rash. Then we have arthritis, that is for A, it could be non-erasive. Then S is serositis, it could be pleuritis or pericarditis. Then we have H is hematological disorders. So there would be cytopenias. Then we have O, so O stands for oral or nasopharyngeal ulcers. It could be painless. Then we have R is renal diseases. Then we have anti-nuclear antibodies, this is sensitive. And then we have specific antibodies that are anti-dsDNA or it could be anti-Smith antibodies. Now for the N, there could be neurological disorders also, so seizures or psychosis. Now there is a cardiac association with SLE, that is Libman-Sec endocarditis. It is commonly seen in people with SLE. And then the renal disease that I have talked about, that is lupus nephritis. That's it for the features of SLE. Now we'll move to the treatment. So if the disease is of mild stage, then hydroxychloroquine and NSAIDs is our treatment. But if the disease is moderate, then we'll have to use hydroxychloroquine with NSAIDs and we have to add low dose corticosteroids to it. And then if the disease is severe, then we'll have to switch it from low dose to high dose steroids. And then along with that, we'll have to give immunosuppressants to the patient. So a new thing got added in e-medicine. So there is a Jacob's arthropathy. It is seen in SLE, but then its symptoms are same of rheumatoid arthritis. So there was this swan neck deformity, but then Jacob's arthropathy is swan neck deformity that is reversible on physical manipulation. So this is associated with SLE. So the question stem, they can show you the picture of swan neck deformity. So don't jump to the conclusion. You'll have to think about if it is reversible or not. Then the answer will change accordingly. Okay. Next is polymyalgia rheumatica. It is the easiest and the AMC asks about it every time. So only thing you have to remember is ESR would be highly elevated. There are 5 tender points. So one is pelvic girdle would be affected and bilateral shoulder pain could be seen. So in the question stem, they can say the patient is having problem getting up from the chair and something like that. Okay, now ESR would also be elevated, but then CK would be normal. It has the strongest association with giant cell arteritis that we have studied in previous video, that was from vasculitis. And then for the treatment, we'll have to give low dose corticosteroids as it is useful in both of them. Now the next is polymyositis, dermatomyositis or fibromyalgia. So for polymyositis, you have to remember that there is a progressive symmetrical proximal muscle weakness is there, and it is characterized by endomysial inflammation with CD8 T positive cells. So this CD8 positive is important, and it can involve the shoulder joints. But then there is another disease, that is polymyositis with rash. Then it is known as dermatomyositis. So there would be 3 important findings. One is Gottron's papule, the other one is heliotrope rash, and the third one is shawl rash. So these 3 things, if they are present, then it is diagnostic for dermatomyositis rather than polymyositis. And then the inflammatory markers would be elevated, the aldolase would be elevated, CK would be elevated, and for the treatment, we are giving high dose corticosteroids. That's it for the treatment. The last one is fibromyalgia. So basically there are 18 tender points. Out of 18, the 11 should be involved, and there would be pain on those tender points. And then fibromyalgia can have normal ESR levels, and only pain would be a clinical finding, no weakness would be there. Along with that, the patient can experience cognitive disturbances. It is also known as fibrofog. And for the treatment, we are advising the patient to do regular exercises, and antidepressants can also be prescribed like TCA and SNRIs. And for the pain, the neuropathic pain, gabapentinoids can be given. Now moving to the scleroderma, with the name itself we'll get to know there is systemic sclerosis happening because of the fibroblast or collagen deposition. So skin findings are very much common. There would be puffy and taut skin, and then the wrinkles would be absent. Other findings can include renal. So there would be scleroderma renal crisis, and for that treatment can be given, that is ACE inhibitors. Then we have GI symptoms. So peristalsis and lower esophageal tone can be compromised, and it can result in dysphagia or heartburn to the patient. Then we can have pulmonary symptoms. So there would be pulmonary fibrosis or interstitial fibrosis could happen. Scleroderma is of two types. First is diffuse, and the second one is limited. So diffuse is a widespread skin infection, and the antibody associated with it is anti-SCL70 or anti-DNA topoisomerase 1, and also anti-RNA polymerase 3. But the next one is CREST syndrome. It is also known as limited scleroderma, and the C stands for calcinosis cutis or anti-centromere antibodies. R is Raynaud's phenomena. E is esophageal dysmotility. Then we have S is sclerodactyly, and T is telangiectasia. That's all for the scleroderma topic. And this photo is calcinosis cutis, and that's it for the whole video. So in the end, I would like to wrap up this video by saying, if you are liking the content, please share it, please subscribe to the channel, like the video, increase the engagement to it, and until next time, thank you very much.